Good evening. This is Dr. Sabuni again. I'm very happy to be with you again today to talk about a very interesting topic, which is how we succeed growing patient treatment with clear aligners, how we can succeed all growing patient treatment in class 2, in class 3, in sagittal and vertical malocclusion, and what is the rule we need to respect in order to succeed all those treatments. This is very important topics. Why? Because we cannot treat all growing patients by the same way. We should start by very precise, very accurate protocol in order to treat correctly those growing patients. Let's talk about my history with Invisalign. When I started with Invisalign, it was in 2006 or in 2007. At that time, it's completely out of our mind to treat kids or to treat growing patients with Invisalign. When to talk about growing patient at that time, it was completely stupid to think to be able to treat those patients with Invisalign. For us, Invisalign, it was only the alignment for adult patient, some very simple cases. In 2009, when Invisalign started for the first time with teen patient product, it was only to make some alignment and to guide the evolution of some permanent teeth. At that time, we should have the first permanent premolars. Then we can, even if the canine not here, we can prepare the place in order to help the canine, the cuspides, and the second premolars to erupt correctly. Then in 2018, it was a huge evolution with Invisalign when Invisalign start with the mandibular advancement feature, which was the huge jump with Invisalign between aesthetic appliance, between orthodontic appliance to make the simple alignment, to orthopedic appliance to treat all malocclusion and to treat as functional appliance, not only as alignment or as simple aligner system. So this progress with Invisalign continue every day. 2 years ago, we started with Invisalign first now. Even with to do the expansion from 6 or 7 years old, we can do it with Invisalign with very big progress. So today, during this presentation, we'll try to cover all those topics, how we can treat growing patient with Invisalign first, how we can treat with mandibular advancement feature, how we can treat all growing patients from 7 to 15 years old with the same success. I work in the south of France in my main practice in Bandol between Marseille and Nice, and I'm consultant in Invisalign Center in Dubai. So in Dubai, I'm only consultant. I control the clinic, I train the staff there, and in Bandol, it's my main clinic. I have 4 partners in this clinic, and we do all technique in ortho treatment, and I start around 1,000 new patients with Invisalign in my clinic in France. So now if we need to answer to this question, how to succeed growing patient treatment with Invisalign. To answer to this question, we need to think about the pillars we should respect to succeed the growing patient treatment. What is the pillars we need to respect? We have 3 pillars we should respect. First pillar, it's the compliance. If the patient not compliant for our treatment, nothing could happen. We cannot do any treatment if the patient doesn't compliant correctly with the treatment. Second question, we need to have a diagnosis. Growth diagnosis is very important because we cannot deal with the patient at 3 years old in the same way with the patient 14 years old. Both of them are growing patients, but 3 years old, it's completely different protocol than 15 and 16 years old. So we need to identify the bone age for our patient in order to help the patient to have the right protocol of treatment. And the last point, to have clinical protocol for each bone age, for each patient. So we need to think about the best option to treat our patient and what is the best encourage management we need to do. That's when we have three pillars. First pillar, the compliance. Second pillar, the diagnosis. And third pillar, the treatment plan. If we have compliant patient and we have the right diagnosis and we have the right treatment plan, for sure we'll succeed 100% all our treatment for growing patient. Let's start by the first pillar, about the compliance, how we can improve the compliance of our patient. So first point, we should engage the patient in the treatment and in the decision to do this treatment. In my clinic, as I said, in Bandol in the south of France, I never ever give my patient only one treatment option. When I explain the patient the problem list, I explain him why we need to do an ortho treatment, I don't mention anything about the appliance. When I finish to explain the patient what is the diagnosis, what is the treatment plan, what we need to do in order to improve the problems, then I start to talk about the appliance. In order to resolve this problem, the open bite, the deep bite, the crowding, and all those problems, we have three different appliances. We have the labial fixed appliance, we have the lingual fixed appliance, and we have the aligners. And I give the patient the advantage and the disadvantage for each option. Then the patient will decide between those options. So indirectly, I tell them when I talk about the braces it's painful. The braces, you could have some white spot around your teeth. We need to spend 10, 5, 15 minutes per day to clean around braces. So I give all the bad things with the braces. With the lingual, it's painful. That creates some irritation on the tongue. It's very hard to clean around the braces. If you have any broken braces, we should come in emergency in order to fix it. Then I go for aligners. Aligners is the more aesthetic appliance. It's the less painful. It's the we can remove it to eat. So I give all the big advantage for aligners. So the patient will decide in 90% of case to go to aligners. So if the patient decide to go to the aligners, I told them, look, the aligner is very good, but you should be very careful because the aligners need very big compliance in your side. Do you think we'll be able to follow the treatment correctly? Do you think we'll be able to commit with this treatment? So if the patient said, yes, I will, in this case, the patient will sign a contract between him and us. So the patient will sign the contract as what he is able to wear the aligners, he's able to respect the procedures, he's able to come to the appointment and to follow perfectly the instruction given by us. So and by this way, the patient decided to go for this treatment, not the parent, not the orthodontist, and the patient commit to go and to follow the treatment perfectly. The second point about the compliance is the duration. It's very important to respect the time we gave to the patient at the beginning. If they tell the patient the treatment time will be 2 years, we should finish the treatment in 2 years. Because if the treatment will be longer than 2 years, the patient will lost completely all trust in us, and for sure he will stop to wear the aligners. So it's very important to be sure about the treatment time given to the patient. And by experience, the maximum of credit of compliance of our patient, it's between 24 to 30 months. So the treatment will be always less than 3 years. 3 years, it's already too much. We cannot have our patient compliant for 3 years. So we should have an average of 2 years as treatment time to be sure the patient will be compliant with our treatment. The third point about the compliance it's the new technology, the intraoral scan, the outcome simulator. All those technology we can use and we can share them with the patient. This generation of the patients think completely differently than us. So we need to communicate differently with this generation, the Generation Z. We need to try to use the same language as them. So we share always this technology with those patients. We try to share this CleanCheck or this simulation by Instagram, by TikTok, by uh, comment il s'appelle? By all the social media. We need to try to use them in order to involve the patient more and more in this technology, so the patient will be more compliant and the patient will be more motivated to share, to show the friends, and to follow the evolution of treatment. So that's very important in order to engage the patient and to improve the compliance, to engage the patient and the treatment, to respect the duration and to have the treatment as short as we can, and third, to have this technology and to share the outcome simulator, the CleanCheck, and all those technology by social media and share that with the patient. This article was published in 2019 in American Journal of Orthodontics, talking about the factors influencing the compliance with removable appliance. In this article, they try to study what is the factor can improve the compliance of our patients with the removable functional appliance. And on the end of this article, they give us some recommendation in order to tell us what we can do in order to improve the compliance of our patients. And they try to classify the problems between some barriers and some enablers in order on the end to find the best way to have perfectly compliant patients in our treatments. And what they give us as a recommendation. So the first recommendation, have effective communication. That means we should communicate, we should engage the patient in the treatment, as I said. So that's very important to understand, to help the patient to understand the target of this treatment, why we do this treatment. Second thing is very important, the characteristic of the appliance. So when we compare the aligners, very small appliance, even if we have the wings still very small, comparing of the extraoral forces, you can imagine the huge difference between the Herbst appliance, the Frankel appliance, and the aligners with the wings. So for sure, as appliance, it's very small, so it's very easy to be accepted by the patient. Third point, the reminding tools. That's very important. And now with Invisalign, I really advise you to download the apps called My Invisalign. With My Invisalign, you can the patient can follow the treatment, can take photos each time when they change the aligners, and he can receive a reminding each time when he should change the aligners for the next one. So by using My Invisalign, available on the smartphone and on the Apple Store and all the stores, it's very helpful. We can use as well with the new appliance to do the monitoring and to follow the evolution of the treatment, the healthcare appliance. So it's very easy to use it, and it's very helpful in order to improve the compliance of our patients. And last things about the prescription of the appliance, we need to inform the patient to change the aligners every week, so the patient can wear the aligners 22 hours per day and he can follow the treatment. So when we respect those recommendations about the communication, about the characteristic of the appliance, about the apps we can download it, in order to motivate the patient to wear the aligners. With continuous wear of the aligners, we are sure by respecting those recommendations to have perfect compliance for our patient. Don't forget, that's really the more important point about the treatment, the compliance. When we have compliant patient, we are sure to have perfectly good results. If the patient is not compliant, if we have the best diagnosis, even if we have the best diagnosis and best treatment plan and best orthodontist, we are sure to not get any result and any improvement. What about the growth study? As I said, it's very important to identify the bone age for our patient and to identify the growth potential for our patient. Two completely different topics, bone age and growth potential. What's the difference between them? The bone age, it's in order to see during the growth curve of our patient where our patient is located. That means if the patient are in the pubertal time, pre-pubertal time, post-pubertal time. So we can decide where the patient is located comparing of the high velocity growth moments. Because we need to identify this high velocity time in order to focus our treatment during this time. Because during this time, the treatment in very short time could give us very high results. And as we said, if we need to improve the compliance of our patient, the treatment should be as short as we can. So if we need to short test the treatment, if we need to have our treatment shorter, in this case, we should we should make our treatment during this high velocity time. Now the second point about the bone, the growth potential of our patient, that's the oxologic growth potential, the genetic growth potential. Why we have some patient big, tall, and some patient short? Why we have some patients getting very good result with our activator and another patient with the same bone age, we stay with class 2? It's because genetically, those two patients are completely different as cells. So the first patient genetically is prepared to have good growth. So with small activation, we get fully correction of the class 2. The second patient, genetically, the two parents are in fully class 2. That means we don't have enough cells to have the full correction of the class 2. If we use the activator, we'll improve the class 2, but we cannot have fully correction of the class 2. So if you need to have right prognosis of our patient, we need to identify the bone age and we need to identify the growth potential of our patient. Tiziano Baccetti, Lorenzo Franchi, and all the orthodontists from the University of Florence did a lot of study about the right timing of correction of the class 2. And you can see here on this curve, we can see the high velocity time. So if we need to use this high velocity time, we need to identify the bone age of our patient. And during this high velocity time, we have 1 year. During this 1 year, very short time, we can get very good results. And in order to identify this bone age, we can check, according of Baccetti or according of McNamara, we can check the shape of the vertebra. And we can identify between CS1 and CS6 the right bone age for our patients. And we can see, according of Baccetti, the class 2 treatment before or during the pubertal growth spurt induces significant favorable skeletal change, which is resection of the maxillary and advancement in prepubertal patient and enhancement of mandibular growth in pubertal patients. That's mean when we do the treatment on the right moment, we can get the right restriction of the maxilla and the right enhancements of the mandibular growth. When we compare that with the patient in post-pubertal or after the pubertal time, where we get only dentoalveolar modifications. That means if we do the treatments on the right moment, we can get the enhancement of the lower jaw. If we do it before, we get restriction of the maxilla. If we do it after, we get dental and alveolar change. So that's very important to understand in these 3 times how we can get 3 completely different answers with the same appliance. That means if we do the treatment CS1 and CS2, we get more than restriction of the upper jaw than the advancement of the lower. If we do the treatment between CS3 and CS4, we get advancement of the lower jaw, enhancement of the lower jaw. If we do this treatment between CS5 and CS6, we go for dental and alveolar movements. So that's very important to understand this difference between these 3 different times in order to decide what we can get in each moment. So we can see here donc CS1, CS2, and this time, if we need to identify those time or those bone age, it's very easy to check the shape of the vertebra. So for CS1, the lower part of V2 and V3 completely flat, and CS2, the first vertebra starts to be curved, and in CS3, the first and the second start to be curved, and CS4, the V2 and V3 and V4, 3 of them are curved. So it's very easy to check first the curve of the lower parts and the shape of the vertebra in order to see and to check the evolution of the bone age of our patient. For sure, it's not very accurate, but it's enough accurate to give us some indicator about the bone age of our patients. So the pubertal time, which is the best moment to correct the class 2, it's between CS3 and CS4. Let's see what the author said about this treatment. For Petrovic in 1994, he said if we use the class 2 elastic during the pre-pubertal time, that means before the golden time to have the growth, we can get maximum 1 millimeter as extra growth for the patient treating by class 2 elastic. And Petrovic said when we do this treatment on the right time, that's mean between CS3 and CS4, we can get 3 millimeters as extra growth. That's mean during 12 months, with the same way, with the same elastics, the same forces, we can get 3 times more results because we do this treatment during the high velocity time. And for Bacchetti, if we do this treatment before the pubertal time and we use the twin block, we can get maximum 1.8 millimeters. And for Bacchetti, if we do this treatment on the right moment, we can get up to 5 millimeters. So if we need to have our treatment as short as we can, we should start the treatment on the high velocity time on the right moment. About the second point, the oxologic growth potential, I worked for more than 10 years with Jean Delair. Jean Delair is French orthodontic surgeon who is the one who did the maximum of articles and research about the growth. So I help him to create cephalometric analysis. And this analysis we studied the area of the ramus of the patient, and we compare this area with the ideal area given by the balance of the patients. And if the results, when we compare the ideal area with the patient area of the ramus, if the result is more than 78%, that means we have very good prognosis, and genetically we have enough cells to have fully correction of the class 2. If the area of the ramus of the patient less than 78%, that means our patients need more and more and more activation in order to correct the class 2. That means we don't have enough cells, we don't have enough genetically potential to have fully correction of the class 2. I wrote this article in 2019. In this article, I try to understand and I try to summarize the protocol we need to do, how we can correct the class 2 for growing patient with clear aligners according of the bone age and the growth potential. In this article, I distinguished 3 different times. The first time before CS2. Before CS2, that's mean between 6 to 8, 9 years old. We are far before the pubertal time. We are far before the high velocity time. So when we start the treatment, which is the Invisalign first protocol, we need to have the correction of transversal malocclusion. So the main target in this time is to correct the transversal malocclusion and to have unlocking on the sagittal and the vertical malocclusion. That means what I need to do is to have fully correction of the transversal. When I finish to correct the transversal, I can have a look of the vertical and the sagittal in order to improve things. And I do maximum 12 months of the treatment, never more than 1 year. During this year, the target number 1, correct the transversal, and target number 2, unlocking on the vertical and on the sagittal. How we can do that? We can do that by aligners only, or in some case, we can use the expander as well. The first article exists about the expansion with the clear aligners was published in 1955. This article was presented before the American Association of Orthodontics Congress, published by Richard and Barnes. He said in this article, we should do the expansion as soon as we can. And he said the best expansion we can do it's before the eruption of lateral permanent teeth. That means more we have length of the roots of primary teeth, more we can get the real skeletal expansion with our slow expansion protocol. That means by doing the expansion with our aligners, when we have enough length of the root of primary teeth, we can get very similar results than what we get with our expander. But if we do this treatment later on, between 9 to 10 years old, when we have very short roots of primary teeth on the late mixed dentition, it's too late to get any results. So we can get only alveolar expansion, which doesn't make any sense. But if we do it on the early mixed dentition, we can get very good skeletal results. So very important to start the treatment as soon as we can. As he said, the best moment it's between 4 to 7 years old, before the eruption of the lateral incisors, when we have enough length of the roots of primary teeth. So that's very important. And it's confirmed by this study from Dallas University. In this study, we compare or we study the results about the slow expansion. And they found the early treatments with Quadelix or with aligner, the same result on the final, we can get an increase between the intermolar, palatal, and alveolar width. That's when we get in skeletal component, dental component, and alveolar component. And they said the molars tends to move with the alveolar bone and through the alveolar bone. That's when we have the dental expansion, we have the alveolar expansion, and we have the palatal bone expansion as well. So that's very important. What about the stability? About the stability, the same stuff from Dallas University said the slow maxillary expansion give us very good short-term post-treatment stability, mainly on the posterior part of the expansion. That's when we do the expansion of the first molar and permanent molar, and for the first and second primary teeth, we have a very good stability, and we should have as less as we can, as small as we can, expansion between the canine. That's mean we should have our expansion more concentrated on the posterior part than on the anterior. So we can get more expansion and more stability of our expansion by respecting and by keeping or maintaining the distance, the width between the canine. McNamara, what he said, McNamara talked about the rapid palatal expansion. The rapid palatal expansion is very helpful on the late mixed dentition. So on the early mixed dentition, aligner is enough. But on the late mixed dentition, we need aligner plus rapid maxillary expander. Rapid maxillary expander very helpful, according of McNamara, not only to take care of the transversal malocclusion, but even to have spontaneous correction of class 2 and class 3 malocclusion. That means this expansion could improve as well the position of the lower jaw, and the class 2 and the class 3 will be improved as well. Let me share with you my first patient treated with Invisalign for growing patients. Emma, 4 years old when she came to us. So as you can see the profile with the class 2, and we can see some anterior open bites, some overjets, and advancement of upper incisors. The intraoral photos, only primary teeth. This treatment I did 10 or 15 years ago. So I asked Invisalign an exception, because I need to check if with this short clinical crown, if the patient will be able to wear these aligners. So it was really something as only by curiosity and as research to understand how the aligners is effective for those patients. You can see what I plan on the clean shake. Only to correct this protrusion of the upper incisors, some expansion, and I add class 2 elastic in order to help the lower jaw to move forward. I was really very surprised. I was very surprised how much the patient was compliant with this treatment. She was really compliant. She wear the aligners perfectly. She removed the aligners. So she respect 100% our treatment. And we can see here the aligners. We can see here the buttons to use the elastic. And after 6 months, the protrusion was corrected, some expansion, and very good alignment. So it was my first experience. I was very happy. Then the patient came again 5 or 6 years after, when the patient was 11 years old. So first time the patient was 4, the second time the patient was 11, and you can see here very big dysplasia on the enamel. So for this patient, Invisalign is the best appliance ever. Why? Because we have all those retention in the enamel. That means the aligners can do all movements without any attachments. Because we have the aligners perfectly fitted on the teeth, and we have all those retention, natural retention on the teeth to help the aligners to be perfectly fixed on the teeth and to make the movements. So I asked the clean check, and this clean check I asked to have intrusion of the upper incisors to improve the gummy smile, class 2 elastic, expansion, alignment, and all that without any attachments. You can see the extra oral photos before treatment, the X-ray, and you can see the clean check. Cut out for the molars and hooks for the first premolars. Some distalization and jump to finish the correction of the class 2, and the space to help the extrusion of permanent teeth. The final situation, we can see the amelogenesis imperfect for all the teeth. We can see the alignment, all the space completely closed, and upper and lower midline completely on. Panoramic X-ray in the end of treatment. The profile, patient smile. As you can see, the profile much better between 4 years old, 11 years old, and 13 years old. And you can see the patient smile before treatment, after the first 6 months, and 11 years old, and when we finish the treatment. So it was very easy. It was very good experience to understand. Even the patient as 4 years old could be very compliant, and even if the crown are very short, is not a problem, and it's not in contraindication to do this treatment with the aligners. And the amelogenesis imperfect, it's the best indication to do this treatment with the aligners, since we have the natural retention of the aligners, which is very helpful to make the treatment and to move the teeth. Now, if we need to talk about the expansion with the aligners, how the aligners make the expansion. When Invisalign started with Invisalign First, we had 3 challenges we need to fix. First challenge, it was how we can make the expansion or make the movement when we have the short clinical crown. And to fix this first challenge, they introduce the special encourage attachments. When we have case with Invisalign First, we have a lot of small attachments of all the teeth. Those attachments will increase the retention of the aligners in order to make the movement. The second challenge, it was how we can make the expansion by bodily movements. How we can make the expansion not by tipping, but by real skeletal expansion and real bodily movements. And in order to fix this problem or this challenge, they introduce special smart stage. This smart stage is to add labial root torque during the expansion. And instead to have the tipping, we have the real expansion. And now the third point, it's about the protocol. As you know, when we do expansion, According to the last study about the predictability of expansion, they found when we do an expansion on the anterior part between the canine, the predictability is around 70 to 80%, which is very high predictability. But the expansion between the second molars is between 20 to 30%. That means the predictability of the expansion of the lower parts are very low comparing of the anterior parts. So Invisalign, in order to resolve this challenge, they create special staging during the expansion. This sequential special staging, it starts by making the expansion only for the first permanent molars. That means the first aligners make the movement only of the first molars and nothing on the anterior parts. That means between the second primary molars on the right to the second primary molars on the left, nothing will move. All of them will be completely stable. We make the expansion of the first permanent molars, and when the first permanent molar are on the final place, they put it in unmovable and they make the expansion of the anterior part. By making this sequential expansion, they use the intra-arch as anchorage in order to make this differential expansion. So by using the 3 protocol, the special attachments to improve the retention of the aligners, the Libya root torque, and the sequential expansion, we introduce Invisalign first by resolving all those challenges. My first patient with Invisalign first, it was Noe, 7 years old. As you can see, the intraoral photos, we have some crowding of the anterior teeth, profile with class 2, and you can see here the intraoral photos. By seeing the intraoral photos, we can see the crowding of 1121. We don't have enough space for 1222. And on the lower jaw, we don't have any space for the 43. So what the treatment target for this patient is to make expansion, to close the space between 1121, open the space for 1222, and open the space for the 42, and correct the midline by moving the lower midline on the left. So that's our target of this treatment. We can see here, we don't have any millimeter for the eruption of the lower canine. So it's very important to create this space, to make the expansion, and to help these teeth to extrude. The fitting is perfect. The patient wear the aligners correctly, and you can see the clean shake for this patient. We start from this situation, opening space for the 43, and look the lower midline, how we move it, and the expansion of the upper jaw, and creating the space for 1222. 5 days wear by aligners. So for all my Invisalign first cases, I ask the patient to change the aligners every 5 days. We don't need more. Last aligners without any additional aligners. Upper and lower midline perfectly on. The space for the 43 and 1222 and the alignment of 1121. That's exactly what we planned in our clean shake. Upper and lower midline completely on, the expansion, the axis of the incisors, and the profile of the patient. And we can see the lateral X-ray before and after treatment. We can see the lateral X-ray before treatment and after treatment. And you can see here panoramic X-ray before and after. And you can see the canine, the right canine before treatment, completely include, and after treatment, when we open the space and this impacted potential canine become completely on the right way to extrude. Upper and lower midline completely on and aligned, and the arch form are completely different than before. And you can see here patient smile before and after treatment. Another example, Noemi, 7 years old. Noemi came to me in order to improve her smile. As you can see here in the intraoral photos or extraoral photos, we can see the profile with the big class 2, and we can see the huge protrusion of the upper incisors. I completely agree with you. She's far before the pubertal time. That's mean I'm far before the high velocity time. If I need to correct the class 2, I should wait 2 or 3 more years to have the right moment to advance the lower jaw. But I cannot leave this patient without any treatment. I cannot leave this patient with this big protrusion of the upper incisors and tell the patient, look, it's too early now. We should come back in 3 years. And if we have any trauma and if you broke your incisors, that's not a problem. So it's very important to do this treatment as soon as we can in order to protect upper incisors, in order to correct this lip interposition, in order to help the lower jaw to grow correctly. So that's the main goal of this treatment. And treatment should not be longer than 1 year. During this year, I will focus on the expansion. I will focus to correct the protrusion of the upper incisors. And if I can unlock the lower jaw, it will be the bonus. I started from this situation. Narrow upper jaw, protrusion of the upper incisors, some spacing and proclination of the upper teeth. X-ray before treatment, all permanent teeth are present, and you can see the huge protrusion of upper incisors. Let me show you the clean check. I upright upper incisors and I advance step by step the lower jaw. You can see what we get on the end of this phase of treatment. The space between 11-21 closed, the protrusion corrected, the lower jaw was completely advanced, and now we have posterior open bite should be closed. I start the second phase from this situation with this second phase with 30 more aligners in order to finish the extrusion of posterior teeth, and we can see the final result. 2 phases, first phase 50 aligners, second phase 30 aligners, in total 80 aligners, 5 days by aligners, 400 days, around 1 year, the whole treatment. And you can see the patient smile at the end of this phase of treatment. You can see the huge difference and the huge change before treatment, after the first phase, and on the end of treatment. In only 1 year, even if we didn't correct everything for this patient, but we did enough things to let the patient now grow correctly. And now the growth will happen on the right way. From this situation before, the lower lip will completely block the lower jaw behind. So we cannot get any growth of the lower jaw. But with this photo after, the lower lip become in front of the upper incisors. So now the growth will continue correctly without any problem. And we can see the patient smile before and after treatment. So that's very important in those 3 examples to understand when we start the treatment before CS3, before the pubertal time, what is our target? Our target is to correct the transversal malocclusion and unlock sagittal and vertical malocclusion. If we can correct, we can do it, but maximum time should be less than 1 year. Now, if we see the treatment between CS3 and CS4, which is the golden time to do this treatment, now we are on the right moment to have the fully correction of the class 2. In this case, if we have up to 2 millimeters, we go for the elastic effect. Only the class 2 elastic will be more than enough to do the job. If we have between 2 to 5 millimeter class 2, in this case, we use the mandibular advancement feature, which is the best appliance to correct the class 2. If we have more than 5 millimeters, mandibular advancement is not enough. We need to have another phase by distalization, or we can go for elastic effect plus distalization. That's mean up to 2 millimeter elastic effect, 2 to 5 millimeters mandibular advancement, more than 5 millimeters mandibular advancement plus distalization, or elastic effect plus distalization. Let me share with you the case of my niece. My niece is 10 years old. As you can see in her smile, we can see the protrusion of the upper incisors, the lip interposition. We can see here the lower lip between upper and lower incisors, narrow smile, and the profile with the class 2. The intraoral photos shows the big crowding of the lower jaw, and we can see the narrow arch, and we don't have any space for the 23. So what we need to do is to open the space for the 23, make expansion, and align the lower teeth. We can see here the panoramic X-ray. We can see the expander. So we start the treatment for this patient by rapid maxillary expander. Why we didn't go directly for the aligners to do the expansion? It's because we are here on the late mixed dentition. So the aligners will not get any skeletal expansion for this case. If we need to go for skeletal expansion, the only way is to use rapid palatal expander. With this expander, I use special shape, covering only the internal part of the teeth. And I keep the labial face of posterior teeth completely free. So I can keep this expander, make my scan, and ask to have the aligners covering completely the teeth. So I put this appliance, I do my activation twice per day, and when I finish the last activation, I cut the anterior extension of my expander on right side, and on left side I keep it. On left side I keep the extension of this first and second premolars because I need to use this expander as anchorage. And in this case I have perfect anchorage in this place to maintain the teeth here in place, so I can open the space for the 23 by using this expander as anchorage. On the right side, everything is perfect. I can move all the teeth. On the left side, I don't need to move 25, 26, 24. I need only to advance the anterior teeth to open the space for the 23. Let me share with you the clean shake for this patient. So you can see here what we expect as a result. That means expansion, alignment, opening space for the 23 by using the anchorage of the expander to open the space. And on the end, 2 millimeter jump by class 2 elastic. We can see here the expander. So 24, 25, 26 completely stable. And I open the space by moving forward 22, 21 in order to open the space for the 23. And you can see the aligners cover perfectly the expander and making the movement. And in progress, we have the canine start to progress. We align the teeth and we finish this phase and this step. And we can see the evolution of treatment before and after, the panoramic X-ray, and patient smile after treatment. So the first stage, when we do this treatment between CS3 and CS4, we have up to 2 millimeter of class 2, only class 2 elastic will be enough. And I manage in the same time the transversal malocclusion by using the expander. Since I'm on the late mixed dentition, don't forget. Early mixed dentition, aligner. Late mixed dentition, expander. Gabriel. Gabriel, same situation, 11 years old. Profile class 2, short face. Big crowding of the top. Deep bite, full class 2 right and left. What we use as treatment for this patient? CS3 to CS4, the bone age. That means it is the right moment to have the high velocity time. So we don't have any time to lose for this patient. We should start as soon as we can by advance the lower jaw. Class 2, 5 or 6 degrees, we have some proclination of the lower incisors. We can see here the clean check. The advancement of the lower jaw, I use always the default protocol of advancement. 2 millimeter by 2 millimeter advancement of the lower jaw. You can see again the advancement of the lower jaw, 2 by 2 millimeter in order to correct completely the class 2. Which is the default protocol. We make the advancement 2 by 2 millimeters. The patient wear perfectly his aligners. And very important for all patients with mandibular advancement feature is to check the wings engagement. When we have the right engagement, that's mean the lower jaw move correctly and we have the right activation effect from our aligners. If we don't have this engagement, if we don't have the lower wings engaged correctly more forward than the upper, that means nothing will happen. We don't have enough advancement of the lower jaw. Here we have the perfect advancement. So everything on track, everything is perfect. And we can see what we get after this first phase. Look, the class 2 before and the class 2 after. We move from 5 millimeter class 2 to 1 or 2 millimeters. You see the difference? On left side, we moved from fully class 2 to 2 or 3 millimeter class 2. We didn't finish yet the collection of the class 2. We know we have more than 5 millimeters, which is 2 phases, mandibular advancement plus distalization. So now we finish the first phase. We do now this scan after to completely correct the skeletal class 2. Now we need to have the finally dental correction of the sum class 2 on the left. So I add 44 more aligners, but now with distalization in left side to finish completely the correction of the class 2. plus 1 elastic on the right, and on the left, distalization to finish completely the correction of the class 2, and we can see the occlusion on the end of treatment. Perfect class 1 right and left, patient smile on the end of treatment, and we can see the profile improvement before treatment, after first phase, and after second phase. And you can see the superimposition showing the improvement of the short phase, improvement of the deep bites, and the full correction of the class 2. And that's the case of all the patients in the same situation. Maxime exactly the same. We can see the profile class 2, long face in this time, that's time, big protrusion, some space between the teeth, same protocol, same bone age, same growth potential, same diagnosis, same treatment plan. What we did, we do the scan, we make the same treatment plan, mandibular advancement, the advancement 2 mm by 2 mm, default protocol. We can see the appliance with the wings, and as I said, very important to check the wings engagement. As soon as the wing engagement is correct, that means the advancement of the lower jaw moving correctly and everything is perfect. We can see the intraoral photos. After this advancement, making perfect correction of the class 2, but creating posterior open bite. Now this posterior open bite, if our patient is short face, something very helpful by adding some more aligners to extrude posterior teeth and to close this posterior open bite. But in case of Maxime is long face patient, and in this case I don't need to extrude posterior teeth to close this space. I need to upright lower incisors in order to delete the interior interferences and to create interior rotation of the lower jaw to close this posterior open bite. That's what we did for this patient. That means from this situation, what we did, we asked new phases. With these new phases, I asked only to upright the lower incisors. By making this uprighting of the lower incisors, we can see what we did. We delete the interferences on the interior teeth by moving back the interior teeth. Then we have the jump to making the auto rotation of the lower jaw. And we can see the final situation with the jump or the space completely closed, class 2 corrected, and we have perfect bite on the end of treatment. Lateral X-ray and cephalometric analysis on the end of treatment. And lateral X-ray before and after treatment. The angle of the lower jaw, we move from 137 to 133. That means we reduce the angle of the lower jaw, which is what we are looking for since it's long face patient, and we increase the length of the lower jaw from 98 to 106. That means we increase the length of the lower jaw by 8 millimeters, which is what we're looking for our mandibular activators. Superimposition before and after. And patient smile before and after treatment. So it's very important to understand the workflow with mandibular advancements, which is we start by the record, then we have the pre-mandibular advancement phase, when we have deep bite or when we have rotation of the upper molars, or when we don't have enough overjet, so we need to have the preparation before to have the wings. Then we have the wings with the advancement 2 mm each 8 aligners. in order to get 1 millimeter per month. Then we have the stabilization phase, the transitional phase with the wings in class 1. Then we have the additional aligners to finish the treatment. Now we can make some adjustment of this protocol. What the adjustment we need to do is to add class 2 elastic before to start the wings in order to help the patient to understand he should advance the lower jaw forward. What we can adjust as well is to extend MA phase in order to have at least 40 to 50 aligners, to have enough aligners and enough advancement phase. And for the transitional phase, we can extend as well to have up to 15 aligners. So by making those small adjustments, by using the class 2 elastic before, extending the phase MA and the phase transitional phase, we are sure to optimize this protocol in order to give the patient the best treatment option possible. My own experience with mandibular advancement, it's around 200 patients. From those 200 patients, I did randomized study. During this study, I chose 20 patients, 14 male and 6 female. All of them had around 37 mandibular advancements, all of them multiple jumps, weekly change, around 10 months for MA phases. All of them I did the X-ray before and after, the photo before and after, superimposition, and cephalometric analysis. By making the statistic, I found improvement of the nasolabial angle for all those patients, improvement of the overjets, improvement of the overbites, and we get exactly the same quality of the result comparing what we get for the other activator. Look, if we compare the result, we can find a great increase in total mandibular length over 6 months. Better patient compliance, no significant change of FMA and IMPA, and simultaneous dental alignment and the anteroposterior correction. So that's very important, and let's make the mandibular advancement completely unique comparing of the all activator. And for sure, if we don't use it, we cannot see the difference comparing of the others. Because if we do always what we always done, we get always what we have always got. So if we need to have something different, we should try to change our protocol in order to get better results, in order to get something new for our patients. Now, unfortunately, we cannot use mandibular advancement for our patients because we have some exclusion criteria for those patients. The exclusion criteria is to have the second premolars or the second primary molars presence. If we don't have either the second premolars or the second primary molars, the system refuses to enroll this case as mandibular advancement case. So Mathilde, 11 years old, when she came to me, she came referred from the dentist since she had an accident and she lost the tooth number 21. The dentist put again this tooth and referred the patient to me in order to correct the class 2 to improve the alignment and the position of her teeth. You can see we don't have any root, we have fully root resorption of the 21. And we don't have the 5, the second premolars, fully erupted. So this case cannot be enrolled as mandibular advancement case. And I told the patient the only way if we need to do the correction is to remove the 21 because we have this 4 protrusion of the upper incisors and we need to reduce the protrusion, and we advance the lower jaw at the same time. Since the patient was completely complex about the aesthetic and about the accident, the trauma she had, we decided to do this treatment in 2 phases. First phase, we decided to make the alignment and to use the class 2 elastic. And second phase, after 6 months, we remove these tooth and we finish the treatment. So we can see the first phase. First phase, we keep this 21 without any movement. I use class 2 elastic with orthopedic forces. And I plan to finish in this situation, this first phase. That's mean the class 2 molars corrected, improve the alignment without to remove the 21. Now from this situation, we can see before and after. So we improve everything, but we're still in class 2. We're still in protrusion. So from this situation, I ask to remove now the 21 at aligner number 2 and to have exactly the same shape as tooth number 11. Look, second aligners, exactly the same shape. Mirror. And I continue to distalize in order to close completely the overjet and to close completely the gap between upper and lower teeth. During this treatment, I use the Pontic to cover the space of the missing tooth. The patient keep the aligners all the time, even eat with the aligners to hide the space. And as soon as we finish the treatment, we put here the bridge to replace this missing tooth. And we finish the treatment with perfect bite on the right and on the left, and perfect alignment of the lower teeth. Patient smile on the end of treatment. The whole treatment was around 2 years, and we can see panoramic X-ray after treatment and patient smile before and after. So the aligner is very helpful appliance in this case in order to hide the space of the missing tooth, in order to have perfect alignment, perfect correction of the class 2, and all that in the same time. Now, if we have the patient on the end of the growth, that means if we have the patient coming to us between CS4 and CS6. So the first bone age, it was CS1, CS2. Second bone age, CS3, CS4. Now the third bone age after CS. Now the growth already done. We are after the pubertal time. Remember what Bacchetti said. If we do this treatment, if we have the mandibular advancement feature, or if we use the mandibular activator after the pubertal time, we'll get mainly now dental and alveolar change. The growth already done now. We don't get any growth by using the mandibular activator. So I don't need to use MA now. If I have up to 2 mm, I use elastic effect. Now the patient between 14 to 15 years old. If I am between 2 to 5 mm, distalization and molar derotation. If I have more than 5 mm, in this case, extraction or surgery. That's it. Up to 2 mm, elastic effect. To 5 mm, distalization, molar derotation. More than 5 mm, extraction or orthodontic surgery. Let's see the case of Noemi. 14 years old Noemi. As you can see, narrow smile, crowding of the anterior teeth, deep bite, short face. What we need improve from this patient? We need to expand her smile. We need to align her teeth. We need to improve the deep bites. We need to improve the class 2 for this patient. 2 to 5 mm of class 2. What is the protocol? Bone age CS5, 2 to 5 mm. The solution is derotation of 1626 plus distalization to correct the class 2. We can see the bone age for this patient, CS5 to CS6. Panoramic X-ray showing all permanent teeth. Lateral X-ray, we can see the class 2, 4 to 5 degrees, and we can see some proclination of lower incisors. Intraoral photos, we start from this position, and we have 57 aligners, 1 week wear, 18 months. Distalization, class 2 elastic, correction of the class 2, and creating some rotation of the lower jaw. Very important to use the class 2 elastic on the right way, on the right place. Look what I did in this case. I used the class 2 elastic between the first premolar to the second molars. Why I use in this way? It's because on the second molars, I looking to making some rotation of the lower jaw. By using the class 2 elastic behind center of resistance of the lower jaw, that's helping to make posterior rotation of the lower jaw. And why in the first premolars? It's in order to be more close of center of resistance. So by doing more close of the center of resistance of the upper jaw, I don't get any vertical component of my class 2 elastic. But for the lower jaw, by using the elastic on the second molar, it was behind the center of resistance, which is very helpful in order to create posterior rotation of the lower jaw. This posterior rotation is in order to increase the height of the lower jaw and to improve the class 2 and to improve the deep bite in the same time. We can see the intraoral photos on the end of treatment. Perfect class 1 right and left, good alignment, good expansion, midline on, and we can see patient smile and patient profile on the end of treatment. And we can see patient profile before and after treatment. So they improved the class 2, and we improved as well the length of the lower face as well. And we can see the profile X-ray before and after treatment. And looking at the superimposition, we can see the distalization of the upper jaw and the posterior rotation of the lower jaw at the same time. The last patient of today is Sami. Sami, 20 years old when he came to me. We can see full class 2 right and left. We have some crowding of the lower, some crowding of the upper. All permanent teeth are here except the wisdom teeth. And for the bone, or the bone already, the bone age already CS6. That's mean the bone, the growth already done. We cannot expect any help from the growth for this patient. What we need to do, we need to distalize the teeth in order to correct the class 2. But the amount of the class 2 are too high to be corrected by distalization. We know as predictability we can distalize up to 3 millimeters. But in this case I have 5 millimeters and I don't have any rotation of the first molar. So the only way to correct the class 2 for this patient is to remove the first permanent premolars. By removing the first premolar, we can, in this case, correct the class 2 and distalize anterior teeth. Mainly it's because it's a very favorable case. With the protrusion of the upper incisors, with the nasolabial angle, we have all parameters helping us to making this distalization and extraction. Looking the clean check, extraction 1424, root control attachments, helping the movements step by step, distalization, mesialization of the posterior, and the space was completely closed. When we respect the G6 protocol, we respect the right protocol by distalization, and we can see the treatment without any bowing effect, with perfect control of the axe of premolars and the canine, and you can see all the space closed and the retention from 5 to 5 in order to keep the space completely closed. The X-ray before and after, we can see the axis of the premolar and the canine perfectly straight, and we can see the retainer, and we can see the X-ray before treatment. So as you can see here, the axis of the canine, we can see here the mesial tipping of the canine, which is very favorable to do this treatment by extraction and distalization. Patient smile after treatment, we have nice profile, we have nice alignment, and very good result on the end of treatment. If we need to take home message from all things we saw during this presentation. First point, comprehensive orthodontic analysis is still required in all our cases. That means we need to have very good diagnosis for our patient. And we need to decide the growth potential. We need to decide the bone age. We need to decide the transversal malocclusion. We need to decide the vertical malocclusion, the sagittal malocclusion. All details about our patient should be analyzed. Second thing, the early mixed dentition is the best timing to make expansion with the aligner, and the late mixed dentition with expander plus aligner. The prepubertal time is the best moment to make the correction of the class 2. That means if we need to correct the class 2, the best moment is between CS3 and CS4, which is the high velocity time we should take benefit of this phase if we need to correct the class 2. Anticipate the use of the auxiliaries. That's very important. If we have class 2, we need to distalize, we should use the elastic on the right place, with the right forces, with the right way, in order to take benefit of all components of our class 2 elastic. So the auxiliaries should be used, should be decided before to start the treatment. Now we can treat all malocclusion of growing patient by using clear aligners and some auxiliaries. The only limit is the orthodontist experience and the patient compliance. Now, as conclusion, don't forget 3 pillars to succeed the growing patient treatment. First pillar, the compliance. Second pillar, diagnosis. And third pillar, the treatment plan. When we have those 3 pillars, patient compliant, doing the right diagnosis, applying the right treatment plan, we are sure to succeed all our treatment and to have the best treatment for our patients. We can scan this QR code if we need to have information about this conference and all references and the articles I mentioned during this presentation. And if we need any question, we have my Instagram account. Please don't hesitate to contact me anytime. It will be my pleasure to answer you and to give you all the answer you want. Thank you very much, and I hope you enjoyed this presentation about how we treat growing patients with clear aligner. So there is some question I receive about the cases. The first question, if I start the case at the age of 4, it's something very exceptional. I don't start all the case at age of 4. That means I start the case at 4 only in very extreme cases. But the best moment to start the treatment is between 6 to 7 years old. When we have the first permanent incisors and when we have the lateral incisors start to erupt. if I retrocline the lower anterior teeth in same time with MA, yes. In same time, I make the advancement, I apply the lower incisors, and I make expansion. By this way, I don't lose any time. In same time, I make the advancement, I apply the lower incisors, and I continue this treatment. But we should be very careful, mainly on the case of Maxime, which is long-faced patient. The advancement of the lower jaw was quicker than the uprighting of the lower incisors. So after the first phase, I end up with posterior open bite because I get an anterior interferences. So we should be very careful to find the balance between the uprighting and the advancement. So we should upright first, then advance to avoid any anterior interferences. What about the nose? For sure, we should control the nose by making the expansion. We improve always the breathing for our patient, and we improve the position. We improve we improve all the functional on the face. Do you have any other question? So it's no more question. Thank you again for your kind attention, and I hope you all very nice evening, and I hope see you soon. Thank you very much.